This week on Beyond Well Science, we're going to turn our attention to open dialogue and chat with psychotherapist and open dialogue trainer Alida Taylor. Alida is a licensed marriage and family therapist. She's a trainer and facilitator. She's based in Tacoma, Washington, and her passion in working from this community-based, non-expert, need-adapted open dialogue perspective is one that's so fascinating to me, and I think anyone who covers the science of mental health. Welcome, Alida.
Thank you so much for having me, Sheila.
One of the reasons I was so interested in talking to you about open dialogue is you said that when you were practicing before, you felt like there was something missing in the way that you were practicing psychiatry. What was missing for you?
I think it was continuity and patient or client-centeredness in terms of a lot of the systems that we have set up in the U.S. are surrounding different levels of care and payment, and the teams of people that serve people in crisis would keep changing. And so the initial time when somebody was coming for help, you know, they might have a different team that evaluated them in the terms of crisis that were defined by the system rather than defined by the person and the family and their social network. So when I worked in the emergency room, oftentimes the not knowing what was going to happen next was a really important space to stay in. But there was an urgency to define and, you know, get them on a track of either in the hospital or out of the hospital, instead of working with the resources in the person's life and being flexible with creating different ways of helping them and sustaining, you know, what they wanted, you know, and what the social network and friends and neighbors and family that may look disorganized to us, but it may be the language that they live in. And I found out about open dialogue when I was kind of almost burning out in the field, and it just made so much sense that I decided to go to Helsinki and take Jaakko Seikkula's training over 2 years to learn to teach it.
When people ask you in the elevator, what is open dialogue, Alida, what do you tell them?
Well, it's the system of mental health service practiced in Western Lapland since the 1980s. Often in an elevator, I might not have time to tell them about the robust studies, and, you know, how it emerged, because it wasn't an implemented model from somewhere else. It emerged from the staff and the hospital administration and all the different multidisciplinary treatment providers looking at how to reduce chronicity and using trial and error, and coming from the standpoint of weaving together training and practice, and making mistakes and figuring it out. And so the 7 principles that I think are at the core of open dialogue actually came from research looking back at what they were doing that was, you know, adhering to these results. Like they didn't like say, okay, this is open dialogue, we're going to try this here. They, you know, looked back and said, okay, well, it looks like the consistent things that everybody's been doing are immediately helping, involving the families, working flexibly and mobily in their homes, taking responsibility for the first call, meaning they wouldn't tell the people to call somewhere else, and then keeping the team the same and tolerating uncertainty.
How many of those things that you just mentioned, Alida, are actually among the 7 principles? Is tolerating uncertainty one of the principles that guides open dialogue?
Yes.
Wow. What are the others?
Polyphony, meaning that all the voices, both inner and outer, meaning the voices in the person's network, their friends, their family, the voices maybe internally that they have that might also be hallucinations, or they might also be our own, as practitioners, inner voices of, you know, what comes up for us in the moment when we hear something, or so everything's on the table, basically.
Wow. You said that when you started practicing open dialogue, something deeply human occurred. Could you describe, maybe even give me an example of what you mean by that?
Yeah, well, there are these moments, and I think they're in the category of what has been named intersubjectivity, when there's space given to create something in between people instead of a hierarchical kind of like, okay, I think you should do this, or psychosis is this, so this treatment should be given, or as opposed to those ways of that we think we know. Open dialogue is, to me, one name given to a curiosity and getting out of the way, having the light touch, like being with people and allowing the differences to exist. So it's a philosophy and it's a way of being with people.
Wow.
That I think can be named many things, but that's why it really kind of has two definitions. It is the mental health service system of care delivery practiced in Western Lapland, but they don't call it open dialogue. They just call it work.
Mm-hmm. Yeah, that makes total sense. When you are talking about the experience of having the human who is going through this crisis involved, rather than telling the person what is next going to happen to them, what changes in that dynamic when they're able to actually make decisions to participate in their care?
Well, I think there's a deep respect that is preserved when we respond this way. And the other answer is, I don't know what happens. All kinds of things can happen, all kinds of possibilities. But for me, it is a very humanizing approach. It takes into account the human rights of a person. If we can create our systems to be more flexible, taking more time and space to create dialogue, to allow dialogue, to, be at the core of what we're doing, I think we would be surprised at how much of a resource and a strength crisis is, and the people that often need help, to me, are my greatest teachers.
Most families, when they are watching a person who is in crisis, almost feel some sort of sense of relief when there is, okay, we have a diagnosis and we know there's medicine, and they want that subjectivity of an answer. And so your approach is asking people to be way more questioning, way more calm, an approach that allows for the uncertainty of what it is we're experiencing as human beings when we're in mental health crisis. Is that correct?
I think that we're answering what is being asked of us more than asking family to do anything a certain way. I think that we are being asked, when we think dialogically and try to apply these principles that created these amazing results of, way lower chronicity and unemployment and neuroleptic use, all these things. What we're doing is we're responding to and allowing space for the family to express what's been happening that hasn't been able to be expressed in the past. Oftentimes the crises are a doorway into communications in networks and families that we can't really explain what they mean. And when we interpret what they are, we take away their own language. And so I feel more of a sense of relief from family members who have sought this way of working, that they finally are being heard.
You are talking about Western Lapland quite a bit, and I want to just provide people who are not as familiar with open dialogue a little bit of history about why this is the course of practice in Western Lapland and how effective it's been in really reversing the course of schizophrenia there.
Mm-hmm. Yeah, well, the hospitals were overflowing at the time, and the municipality in Western Lapland also, which is really like the county, just started doing things differently. Birgitta Alcara was the medical administrator and head psychiatrist there, and started to bring in trainers, Tom Anderson, Jaakko Seikula, just trying to do things differently. And that led to Jaakko Seikula doing many, many studies in showing what it was that they were doing. And because he did that, that's how it got attention, basically, since 1979 or something. So in response to that, many people have taken these principles and pursued ways in their own contexts, like in the United Kingdom. There's a study going on. There's been studies in Italy, in Germany. And so right now, even how I came to this interview was the Foundation for Excellence in Mental Health Care is funding, and one of the funders for the first multi-center international clinical trial of open dialogue, looking at multiple sites internationally, and is going to measure over the next 6 years.
One of the questions that I have is, the current healthcare system especially is really centered around things like, are you inpatient? Is this an emergency? Do we have a bed for you? How long can you stay? What is your insurance going to cover? How does open dialogue intersect with the current mental health system, the way that it's structured currently?
In the U.S.?
Yes.
Well, I think that it's really up to each individual local context to look at how the current systems they have can be adjusted if they want to, really look at how their system of care can be more dialogic in practice and incorporate the ways in which Western Lapland was working into what they're doing. I can't answer for every local community how they would manage that, but I definitely think it's possible, especially if everyone's at the table. Hospitals, Medicare guideline makers, making sure there's CPT codes for multiple clinicians in the room so that the people that learn this can practice it, and redefining, what help looks like. One of the great things about the way open dialogue is delivered is that at the beginning of services or crisis, the help is given immediately, and the beginning of the treatment meeting, which includes everybody there, is asked, how would you like to use this time? And at the end of the meeting, they say, where would you like to go from here? So whether a person needs hospitalization or needs somebody, a nurse to stay overnight in the home to create safety, or to, help the person get to sleep, or whatever's happening, there isn't a structured, defined treatment that says you have to do this.
Mm.
Of course, sometimes if somebody's really dangerous, there might need to be a hospitalization, but the course of treatment doesn't stop unless the person and family says, we're good right now.
I have been really stunned by the outcomes that they've had in Finland when working, especially with people in psychosis. And I read a statistic that said 75% of those experiencing psychosis in this open dialogue setting in Western Lapland returned to work or study within 2 years, and only 20% of people were still taking antipsychotic medication at a 2-year follow-up. Those kind of results are so astounding that I think some people would say, how can we do that on a bigger, wider system? That's impossible. This is only going to work when it's one-on-one, really intensively with people.
Well, they don't exclude somebody getting one-on-one treatment. That may occur here and there, but the main practice of open dialogue is that everyone works together, and they work flexibly, and they bring in all the voices. So there's not a attitude of well, we don't want this person there because they'll disrupt the meeting or something like that. They're welcoming all of it, all the different voices.
And is it the belief, Alida, that these voices have something to inform, to share? Is it a link to past trauma? Is it something that the person really needs to be aware of for future growth? What's happening there?
Well, on a philosophical level, from the reason it's called open dialogue is that it's based on the fact that self, like some of Mikhail Bakhtin's work and other philosophers, that the self is defined with others, sometimes through others, and we are social animals, basically. And we're learning this from, science now, that the vagus nerve, that our whole nervous system and attachment and how we come into the world, there are communications happening all the time, that when we're all in the room together, the possibilities are infinite for the growth to go in its own direction. And we respect the language and the rhythm of each family, rather than renaming their words and calling them symptoms or calling them by a certain diagnosis. In fact, I don't even need to understand what's happening. I don't just providing the space sometimes leads connections to happen that they have, that they somehow feel better about, that I don't know how that just happened.
Wow.
And I don't maybe need to.
There was a recent study, an outcome on open dialogue in psychiatry research that showed statistically significant reductions in unemployment, hospitalizations, long-term neuroleptic use, disability allowances, and mental health service usage. And, here we are in Portland, Oregon, where you don't have to walk very far down any sidewalk before you see someone who is talking to voices in their head and homeless, and the crisis is unfolding in a human way on our streets. And I'm just curious whether or not you think that this is an approach that could be used with those people, especially in the homeless population, that have been uncared for so long. Like, is it more important to get to a person when they first begin this mental health journey?
I think all of that's important. I mean, I don't think we should forget, about what people's experiences have been to lead them to this chronicity, and listening more is necessary. I mean, there's lots of room to develop open dialogue based programs that approach in the homeless populations. There's work in France going on right now, specifically with that population. There's trainees in my courses that work in that population. So I don't think it's more or less important to bring it one place or another. The only reason that the studies exist in early psychosis in particular is because when you do a study, you have to pick something that you're measuring. And so that's why we have all of that data. It doesn't necessarily mean that it doesn't work for, lots of different things. In fact, the way they treat and deliver services in Western Lapland is to anyone who needs help. It's not somebody with just psychosis.
We're going to be talking more about open dialogue with Chris Gordon, and I know that he's actually set up a structure to use open dialogue in his practice. How often are you using this technique now? Not in just people with schizophrenia, but in just people with anxiety, depression, hard times, hard financial times. Does it work for all of those things, the entire spectrum of mental health?
Well, it's a sensibility. It's an approach. It's a philosophy that now that I know it, I can't unknow it. And so I approach all of my clients with this idea that, for instance, I got rid of my couch and I only have chairs. And sometimes if I'm seeing individuals for the first time, they might be curious about that. But sometimes what happens as a result is they bring in their family members when they want to sessions. And I also see clients and families with another professional as often as I can, and our practice is working towards developing our credentialing contracting person is, pursuing writing codes for this so that outpatient practitioners can have an easier access to getting paid, and that insurers can start to look at what they're really offering. Because I think when you include the family and you include the social network of the person, you're including the resources that they have, and people are able to get better in the context of their loved ones, rather than as an individual only. I wonder sometimes. I mean, I should be working myself out of a job is how I look at it, and how all of us should be looking
I love
at
that.
it.
I wish every psychiatrist felt that way, right? I want to just end by having you add on to a beautiful blog that you wrote where you said using open dialogue allowed you to feel and to touch and to experience something ineffable, a shared language, something deeply and autotomically human, yet unrepeatable and fleeting. It led me on a moment-by-moment path where everything I learned in my career about systemic family therapy and emergency psychiatric protocols ebbed, and the present moment of love flowed, neither the ebbing knowledge nor the cresting wisdom having any lesser value than the other. I find that to be so poetic and so human. Do you want to just wrap up here, Alida, with any other thoughts in that direction?
Wow, it's nice to hear that I was in a good moment to write that.
Yeah, well, it's beautiful. And it really does. I think it speaks to how in a mental health crisis, I think everybody knows who's been through it, that what is most important is the feeling that the person is going to be heard, to be seen, and to have someone who cares about their recovery. That to me feels like the most important aspect of open dialogue.
Yeah. And I would guess I would add that I feel like most people called to do this work know this space quite well. And I would like to, I guess, encourage them to challenge the concretized systems and the dangerous risk assessments that limit, what could be in more of the analog space.
Mm-hmm.
And to really voice their own discomfort with having to practice in an inhumane way, and be open to opportunities of learning to be more dialogic in all of their practices. This has really affected my own life too. Just personally, I just feel more fulfilled working this way, even though it's more difficult and new to a lot of people. It's rewarding to me on all levels and brings me more purpose.
Alida, it's been so wonderful to speak with you today. Thank you again. Alida, a licensed marriage and family therapist. She's a trainer and facilitator. She's based in Tacoma, Washington, and her passion now is working on and from this open dialogue perspective. Thanks again, Alida.
Thank you for having me so much.